the 1 to 2 year fellowship, my program was online. There are some programs where it's connected to a family practice residency and it's included within it, but I had a completely separate fellowship for integrative medicine. And what is integrative medicine? Well, integrative medicine, I think of it as all of the other healing modalities that can help a person improve their wellness. And that's usually not included in Western care. So in Western care, like when you go to medical school, you learn really about this is the disease process. We match a diagnostic tool along with the medication to treat it. There is more talk about preventive medicine, lifestyle medicine. Now, I think maybe more so than when I went to medical school, but integrative medicine really incorporates all of those other things. So it really focuses on promotion of wellness, not just focusing on the disease state. We sort of support, the wellness state. Physicians who have integrative medicine fellowship or have extra training in mind-body medicine. So those are sorts of like breathing exercises. We talk a lot about meditation, motivational interviewing. Nutrition is really emphasized. We learn about naturopathic medicine, herbal medications, natural supplements, Chinese medicine, and Ayurvedic medicine are also incorporated in integrative medicine. Some things I'd include here are, manual medicine, energy medicine. So it's, all evidence-based approach to care and how we can help a patient in their journey towards health. And sleep medicine. So I combine the two together. So sleep medicine, in my fellowship, we focus mainly on obstructive sleep apnea, and that's generally what a lot of sleep medicine physicians do. Sometimes they have a background in, a whole host of other fields as well, such as psychiatry, neurology, and they incorporate those aspects. I practice pretty much 100% integrative sleep medicine. Some people have a hybrid practice. I also help people who have excessive daytime somnolence. They can have narcolepsy, insomnia. I'll talk about some of these conditions as we go with our talk today. Shift work disorder, people who work overnight and have a hard time sort of reincorporating to daytime life, restless leg syndrome, parasomnias, and circadian rhythm disorders are all within the realm of what sleep medicine physicians do. Sleep medicine physicians also help people throughout all ages. There are, babies, even neonatal babies who have difficulties breathing at night. A lot of times that's due to different syndromes where they have different facial abnormalities, even in elderly folks who have difficulty breathing. I think the oldest patients I had are in their 90s, and they still have obstructive sleep apnea, and they're being treated from that. So what's nice about sleep medicine is we can help patients from the whole lifespan, from birth even to older age and geriatric age. So going back to a variety of sleep physicians, so myself, I have a background in internal medicine and integrative medicine. Internal medicine physicians are sometimes also called primary care physicians. General physicians for adults is what internal medicine is. Some sleep physicians also have a background in pulmonary medicine or lung medicine. Some have had training in neurology, so they're brain specialists. I have some friends who are psychiatrists who also practice sleep. Otolaryngologists, generally these are the surgeons. They do the sleep apnea surgery, which I'll talk about, people who have big tonsils or crooked noses. I have seen, not too frequently, but a women's physician, obstetrician and gynecologist, who has a specialty in sleep medicine, also not as common, but cardiologist. Because if you think about it, if you do cardiology, it's 3 years of internal medicine, 3 years of cardiology, and then another year of sleep fellowship. So after med school, that's actually 7 years. But I have seen online there's heart specialists who are sleep specialists as well. And actually, there are certain dentists who have a background in sleep medicine as well. We'll talk about how they play a role as well. So what's really nice about sleep medicine is that there's multiple specialties. We really provide collaborative care for our patients. So a day in integrative sleep medicine. So, I just put this line here, mix between clinic and reading sleep studies. So right now what my practice consists of, and I'm in private practice, which means I own my own practice. I was previously employed by a big hospital system for the past 4 years. I'm still part of this hospital system as I'm helping create their pediatric sleep lab. But right now, I have most of the time that I spent, I work Tuesdays through Fridays in my own clinic. And so usually what I do is I see patients, I do new sleep consultations, new integrative consultations. The integrative approach means that when I have my patient intake, I ask them about their stress, I ask them about their nutrition, I ask them how they're dealing with their stress, if they need help with that, because that certainly plays a large role in why people have a hard time sleeping. So, depending on how many consults I have during the day, it could be, 5 to 6. I also do follow-up. Most of the follow-up care is for people who have obstructive sleep apnea, which I'll talk about in a little bit, and also people who have insomnia. I have been trained in cognitive behavioral therapy for insomnia, and so I can provide those classes for patients. And I also read sleep studies. So since I'm still affiliated with the hospital system, I read in-lab sleep studies for pediatrics, and I also have home sleep study kits available that I provide to my patients in my private practice. So I'll talk a little bit about what that looks like. I also like to spend time educating about sleep, and so some of the time that I have during the daytime is I'm creating some videos for social media. I also have given some talks for different summits. I'm getting more involved in podcasting as well. So I think it's really interesting as you have your medical degree, as you're a physician, you're an authority in the field, you're an expert. And so people will come to you for, basically advice or help with some of the marketing of their campaigns. And I think it's really nice to be able to educate. And I think that's just part of also why I really like being a physician, because it really, I have this platform where I can speak with an authority and really share a lot of the things that I've learned about. So it's not just one-on-one with my patients. It's able to be broadcasted throughout essentially the whole world, depending on my collaborators' audience. So let's talk about obstructive sleep apnea. Sometimes we just say OSA, in sleep and in medicine, all the different fields have all these sort of acronyms, these code names, and certainly in sleep we have them as well. So obstructive sleep apnea, we shortcut it and say it's just OSA. So obstructive sleep apnea is pretty much, the bread and butter of what I see on a regular basis. I would say probably 80% of my practice is consisted of people who have this condition. This is a graphic representation of what's going on when someone who has obstructive sleep apnea. So this is a side view picture here. Up here are the eye sockets, the nose, and the mouth, and they're laying on their back. So the blue arrows represent the air and the oxygen flowing down into the body. And this is the normal breathing pattern. So snoring, I don't know if you've heard, but this is sort of a big red flag. Snoring actually is not normal. So if someone snores, it could be a sign of having a medical issue. So if someone snores and the snoring is because the air has a hard time going through the nose, it could be that the nose is crooked. If they've broken their nose, part of the wall could collapse. We call that nasal septal deviation. Sometimes people who have allergies, or if you have a cold, you see these folds of tissue here. They're called the turbinate. Sometimes those are enlarged, keeps the air from flowing through. Sometimes people can have tumors or polyps in their nose, and that can also lead to snoring. Snoring can also happen further downstream. This structure right here is the tongue. At night when we sleep, our muscles relax. Sometimes it relaxes so much to the point where the tongue can fall back and close off the airway. Even downstream, you see this tube here. Usually what I like to say, and I actually do this with my patients, is I have a piece of paper that I roll up and then I narrow it, right? So if the tube narrows, this is basically what happens when you have a wind instrument, right? Air moves through a narrow tube. Air moving through a narrow tube makes a noise, and that's what snoring is. And then the last picture there is when the airway is a little bit more collapsed, right? Because at night when you sleep, your muscles are relaxed, then air has a hard time going through, and there's a reduction in airflow. We call that apneas. So obstruction, there's a physical blockage in the airway. It only happens during sleep. So if people have a hard time snoring, if people have a hard time breathing when they're awake, it's certainly a separate issue, and apnea means no airflow. So if this process happens at least 5 times an hour, that's considered obstructive sleep apnea. Why does it keep repeating itself? Well, your airway narrows and closes, and your brain says, hey, you got to wake up and breathe, right? Your evolutionary response is to breathe breathe is to get enough air and oxygen into your body. So you have to wake up and breathe. Sometimes people know this this happens to them because they wake up choking or gasping, and sometimes they don't know and they wake up just feeling really, really tired, right? So if you know someone who snores or has difficulty breathing, I would really encourage them to talk to their healthcare provider about this and see if they have obstructive sleep apnea. Some of these things listed here are things that can worsen snoring and obstructive sleep apnea, right? Alcohol makes the airway more floppy. The muscles relax even more. Sometimes people snore more when they drink. Sinus congestion, right? If you had a really basically blocked up nose from phlegm in your nose, that can cause difficulty for the air to go through. Supine position, this means when you're flat on your back. When you're flat on your back, gravity is more likely to pull down the tongue and close off the airway. Testosterone replacement, so people who, usually men who are on testosterone replacement for hypogonadism, the testosterone can actually make the airway more floppy. So it's really good to get a baseline sleep study to make sure that the testosterone isn't a reason why, they can have problems with oxygenation. And then there's certain medications, pain medications called opiate medications, and then hypnotic. Those are known as sleeping pills. Those really, put you to sleep, relax the muscles, and can make sleep apnea worse. And then REM sleep or REM sleep. REM is a part of the night when we're dreaming. It's a specific stage of sleep. Usually during this stage, our muscle tone decreases, so our airways can narrow, and sleep apnea events can be worse in this period as well. What is this? Well, if you look at the picture on the left, this is called the Mallampati score. So actually, it was created by anesthesiologists, right? So anesthesiologists are physicians that help you breathe when you're in surgery. So they want to look inside someone's mouth and see, how easy is it for me to put the tube in their throat? So 1, 2, 3, and 4. Guess what? The sleep physicians sort of adopted this scale and said, oh, this works well for us, right? So people who have a scale of 3 or 4 on the Mallampati scale have more higher risk of having obstructive sleep apnea. This makes sense. Why? Well, the tongue actually is the same size. The difference is the hole in the back of the throat is smaller. And just think of a room, if the walls were closer together, and at night when you sleep, if the walls collapse in and of itself, more likely to have obstructive sleep apnea events. So a class 3 or 4 Mallampati score will increase your risk for having obstructive sleep apnea. What that looks like is, if your jaw was a lot smaller or pushed back like this. Sometimes I push my jaw back and I have a hard time even breathing like that, right? Everything is just more smushed together. And then on this side here are tonsils, right? So 0, you don't see any tonsils. 1, 2, 3, 4, you can see they're subsequently getting bigger. And in the fourth picture here, the tonsils are so big that they're touching, right? Usually in kids we see this, but certainly some adults can have this as well. They can have snoring and even obstructive sleep apnea based on their tonsil size. So doing a sleep study will basically roll in or roll out, tell us whether or not they have a sleep apnea, and then we can send them to surgeons to take that out. And usually I would say if they're class 3 or 4, as long as they're not obese, that can resolve their sleep apnea. So all the different signs of sleep apnea, right? So apnea means no airflow. So sometimes patients don't necessarily know that they have this. So if someone tells them that they're high risk for having it, snoring, as we talked about, why that can lead to sleep apnea, choking or gasping upon awakening, difficulty maintaining sleep. So usually people who have sleep apnea can be quite tired, but then they have a hard time staying asleep, and it's because of this, right? Their brain is constantly waking them up to tell them, hey, you got to wake up and breathe. For the same reason, right? Waking up in the morning just unrefreshed. You're still tired. You want to hit the snooze button. Yeah, because of that. Multiple awakenings at night. Sleepiness during the day. Same reason, right? Your brain needs rest at night. And if it's still activated because it's telling you to breathe, you're going to be feeling pretty tired. Headaches in the morning. This can be due to difficulties with different gas exchanges, right? We inhale oxygen. We exhale CO2. Sometimes if the CO2 levels rise, it can be associated with headaches. Memory impairment. So sleep and memory are so important. So if you guys are in school, I really encourage you not to pull over all-nighters. Why is that? Well, because during sleep, it's when our brain actually moves the files from the short-term memory into the long-term memory, right? Our memory gets consolidated. So if you're sleep depriving yourself, or if you have an underlying sleep condition where you're not getting adequate sleep, then this process is disrupted and it can really affect your memory. Concentration has also been associated with having obstructive sleep apnea, similar to reasons for memory issues, and urinating at night. This is one of my favorite things to explain to patients. So what's going on with that? So going back to the analogy where the tube is narrowing or collapsing, think of it just like the plumbing system where you live, right? So if the airway is narrowing up here, you actually have to expand your lungs a lot more to overcome that narrow airway, right? So when you expand your lungs, it creates an increase in intrathoracic pressure. The expansion of the lungs causes more pressure in the right atria, which is the top part of the heart. The top part of the heart will actually stretch and signal for your kidneys to say, hey, you got to wake up and urinate. Stop holding your urine, right? Just like going back to where you live, right? If there's too much pressure within the system, you have to turn on the faucet, open the spigot, relieve that pressure. So I've had patients who've woken up every hour, and it's not a prostate issue, it's not a bladder issue. They stop drinking water, and really it's from sleep apnea, right? So once you open up that airway, open up the pressure back in here, then the system is actually more balanced, so there's not a buildup in pressure, and so people don't urinate at night, which is really comforting for a lot of patients who have this issue. And there's also specific hormones involved. It's actually called the antidiuretic hormone, or ADH, that gets stimulated when the heart stretches. So how common is obstructive sleep apnea? Well, it's pretty common. 1 in 5 adults have at least mild OSA, so that's at least 5 times an hour where they have difficulty breathing. 1 in 15 has at least moderate, so moderate means 15 events per more, or 15 events or more per hour. And I don't know if you can guess. I think the highest that I've seen reading a sleep study was actually over 100. I've seen people have difficulty breathing over 100 times on my sleep studies. Certainly, they feel so much better once they're treated for their sleep apnea. So how do we diagnose it? There's actually 2 different ways. The in-lab polysomnogram, which is considered the gold standard diagnostic tool for diagnosing sleep apnea. There's a diagnostic PSG. So PSG is our nickname for polysomnogram. Split night study is when we watch patients for 2 hours of diagnosis, and they have so much difficulty breathing, so much sleep apnea events, so we put them on the PAP therapy, which is the treatment. The PAP titration study. So PAP is positive airway pressure, and that's the treatment for it. So a PAP titration study would mean that we already know the patient has obstructive sleep apnea. Now we're placing them on the machine for the whole night. Another test that we do, actually, I'm sorry, this isn't for OSA, this is actually for narcolepsy, is the multiple sleep latency test, and that's a napping test. And I also mentioned before in my private practice, I provide home sleep apnea test, right? So technology, the way that it is so good that we don't need all the fancy bells and whistles of the sensors that is done in the lab, and so I can actually give someone a kit. They take it home with them, sleep in the comfort of their own home, represents a real world environment, and then I can diagnose with sleep apnea that way. So the in-lab polysomnogram, if you can see here in the middle picture, this gentleman has EEG leads on, so everything is external. There's stickers on the head that actually tell us, how fast or how slow the brain waves are going. So when we look at what sleep is when the brain waves start to slow down, and then there's characteristic patterns for the different stages of sleep. Attended polysomnograms are attended, meaning there's a sleep technician monitoring them on a computer outside the room, and if they have enough obstructive sleep apnea events, then we would put a mask on them, right? And that's the treatment. Home sleep apnea testing, so there's 2 different types. This is called the WatchPat. It's a really interesting device here. This wrist device here tells a physician if a patient is awake or asleep based on movement. So think of it like a medical grade Fitbit. This is a pulse oximeter, so it measures your oxygen and your heart rate, and then there's a sticker on your chest. So we can diagnose if someone has a breathing issue based on how long it takes the heartbeat to go through the whole system. In this WatchPat test, there's actually nothing on the face, which is really important for some people who have a hard time with things on their faces. The NOx T3 test is what I have in my clinic. It has this same wrist device that tells us if you're awake or asleep based on movement, pulse oximetry for oxygen and heart rate. This one actually has a oxygen sensor. This is a nasal cannula. It's a nasal cannula that monitors flow. And then there's two belts that a patient wears to see if their chest is rising and falling. So this, I would say, is a more classic type of device, and then this is a newer technology based on peripheral arterial tone. But either has been validated as compared to in-lab sleep studies to tell us if a patient has obstructive sleep apnea. One caveat though, if you're lying in bed awake, not sleeping because you're nervous that you have the sensors on you, then we really can't measure whether or not you have sleep apnea, right? So if you're laying awake still watching a movie, it could look like you're actually asleep, but since we don't have the sensors on your brain, we don't know for sure. So home sleep apnea test, if they are negative, if they're normal, and a patient is high risk for sleep apnea, an in-lab study is still indicated because it is the gold standard, because we know for sure if a person is awake or asleep when we're looking at their brain waves. The actigraph or the accelerometer from the wrist device here only gives us a clue, but it's not 100%. Yeah, it's pretty accurate though, I would say 90%. All right, so going back to the severities, right? So this is based on either test, either the home or the in-lab test. If you have difficulty breathing that's less than 5 times an hour, that's normal. You know, we say obstructive, it's observed sleep apnea or snoring would be the diagnosis. And then there's mild, moderate to severe. And I think the highest number I've seen is over 100. How do we treat sleep apnea? Well, weight loss is really important. You know, going back to that tube analogy, right? So if your airway looks like this and you have extra fat and soft tissue pushing on your airway, higher risk for having sleep apnea. So for men, this is if men have a neck size of more than 17 inches, and for women, it's 16 inches. Surgery, we can talk a little bit about removing tonsils. CPAP, that's the continuous positive airway pressure, wearing the mask on. Mouth guards, what mouth guards can do is move the lower jaw forward. The tongue is connected to this bone right here, so when you move that forward, you get more space in the back of your throat. So that may be good enough for sleep apnea. Usually if the sleep apnea is mild, I've seen a few cases where I worked in severe patients, but usually dentists who do this say it's definitely good for snoring and mild sleep apnea. But keep that in mind, right? If the snoring is in the nose, moving the jaw forward doesn't necessarily help. Positional therapy, so that's sleeping more upright or sleeping on your side. Now we have special technology. Like there's a little belt that you can wear, and if you turn on your back, it gives you a little bit buzz and tells you to turn on your side. Back in the day, we actually would ask patients to wear an old t-shirt and sew some tennis balls in it, so it'd be uncomfortable when they would be on their back. And there's also something called myofunctional therapy, which is basically doing exercises to strengthen the upper airway. I don't know if you guys are familiar with the musical instrument from Australia called a didgeridoo. It's like this long pipe and it goes wow, wow, wow. So basically there have been studies where people who have obstructive sleep apnea, they learn to play the didgeridoo, and it can actually improve some of the sleep apnea symptoms, right? Really by strengthening the muscles of the upper airway. So talking a little bit more about specific treatment. So I do diagnosis of sleep apnea, then I talk about treatment with my patients as well. These are examples of machines. This is different types of CPAP machines that blow in pressure to keep the airway open. This is actually a travel machine here. It's about the size of a smartphone. So if people who travel don't want to bring their big machine with them, they can bring this small machine. The machine is so smart now. We can do home sleep studies, meaning the home sleep studies can diagnose whether they have sleep apnea, and then we can put a patient on a wide range of pressure, and that's the automatic positive airway pressure machine. And the machine is smart enough to deliver the amount of pressure that they need. It can actually sense, sort of through a sonar device, how much the airway is closing. Bilevel positive airway pressure just means that there's two pressures, one when you inhale and one when you exhale. These are what the mask interfaces look like. Yes, there are people who use a device that looks like this. So some people, are not able to keep their mouth shut. And so if that's the case, we give them a full face mask, a mask like this that covers their nose and their mouth, or a chin strap. So what the chin strap does, it keeps their mouth from falling open. There are certainly smaller devices, such like this. It just goes underneath your nose and is really helpful for people who are able to keep their mouth shut. There are people who can get used to keeping their mouth shut, so you don't have to wear an apparatus such as this. Yes, and people do really sleep like this, and they do feel much better. I don't have the picture here, but I'm sure you've seen them by the side of the road. I like to call them the waving arm men. Usually they're by car dealerships, right? And so when there's no, they sort of wave like this in the wind, and when there's no pressure, they flop over. That's essentially what the CPAP machines are doing. Blowing pressure, just sort of like a balloon to keep everything open, because when it collapses, then the air doesn't pass through and there's no oxygen. So it makes a lot of sense from a physics standpoint. Technology is so amazing. People can download an app that's connected to their machine, and it gives them this fancy score. You can sort of see the numbers here, some of the data that patients can see. It doesn't read sleep, right, because we need EEG data to look at sleep. It actually just looks at duration when the machine is on, which could be a correlation to sleep if you're only using the machine in your sleep. So this gives hours. It tells if your mask is sealed. It gives you events per hour. So say someone has difficulty breathing 10 times an hour with the machine, it can say that, oh yeah, last night it was 2, so I would say that's really good. Less than 5 is normal, and even reads if you take your mask on or off, right? So, engaging patients with their data is a good way to help encourage them to use it. And also, insurance companies do require it. They require patients to use it at least 4 hours a night, 21 days, or 70% in the first 3 months. Because if they don't use it, the insurance company doesn't want to pay for it because they are expensive machines. So during my follow-up visits with patients, I talk to them about their sleep results, and I bring them back and I put them on the CPAP machine, and then we look at their data together, and we say, oh, is it working for you? Is it not working for you? How can we adjust? Do you need a new mask? Do we need other treatments to help you fall asleep? And we go from there. I generally like to take an individualized approach to care because I think that's most helpful for patients, meeting them where they need. So you can read this while I just take a sip of water here. I think this is a really great cartoon. Treating OSA with PAP. Does it work? And this guy talking to his friend in the meeting. What's that? It's CPAP machine. It keeps me from snoring during meetings. Yeah, so generally it does help with snoring, but it maybe depends on what's going on in the meeting if it's not quite interesting. So hopefully everyone's staying awake here. But CPAP machines do work for snoring. Ultimately, it also treats obstructive sleep apnea, which is its main goal. Other treatments, right, we talked about mouth guards. So sleep dentists would create this after creating a mold of your mouth, moving the jaw forward. They would know how much to adjust it. Then we do another sleep study to see if it actually works. The ear, nose, and throat surgeons can take out the tonsils. They can straighten the nose. If someone has a crooked nose, you can see here if the nose is so crooked, the air has a hard time flowing through. This study was done a lot, probably in the 90s and 2000s. It's called the UPPP, or uveal palatopharyngoplasty, removing the uvula, cutting off some of the soft palate. The benefits aren't as good, all right, because I think a lot of times what happens is the tongue falls back and closes off the airway, or the muscles downstream as we get older just really get a lot weaker. And so that could be a reason why people have obstructive sleep apnea. But there are devices besides the CPAP machine that can help, but the CPAP machine is still the gold standard, and it's the best treatment option. A newer technology is called the Hypoglossal nerve stimulator. It's marketed as Inspire. Think of it like a pacemaker. So you see there's a wire here. It's implanted into the chest. It touches the diaphragm and also the hypoglossal nerve, which is the nerve for the tongue. So it senses when the airway is narrowing or collapsing and gives you a nice little zap to keep the tongue nice and taut so it doesn't fall back and close off the airway. Sounds pretty invasive, but actually it's actually pretty beneficial. Not as good as CPAP, but there are patients who aren't able to tolerate CPAP, can't use the mouth guard, don't have any other surgeries that are available to them, and then actually do notice improvement with the stimulator. What are the benefits of treating sleep apnea? I know I didn't talk too much about the health benefits, but essentially if you can think about it, what happens to your body when you're not getting enough oxygen at night, it increases your risk for heart attack, stroke, irregular heartbeat, cognitive impairment. So some of the end effects of treating sleep apnea is this. Patients are less likely to be admitted to the hospital because their heart disease is controlled, less likely to have a heart attack or stroke. I love to hear this one. People are less tired and have energy to exercise. One patient actually told me, I don't have any more excuse not to go to the gym because I'm feeling so much better. Memory, mood, concentration aren't much better. Sometimes patients lose weight just by getting better sleep, and by the time they come back in my office, I don't even recognize them anymore. And then this one I talked about as well, waking up less at night to urinate. All really good benefits of treating sleep apnea. And one of the benefits of sleep medicine, sometimes in primary care, some of the diseases that we treat are chronic conditions, and we don't necessarily see a benefit. Sometimes it takes a couple of years to notice some benefit. With sleep apnea, after we diagnose and treat them, as long as they're able to use a CPAP machine or have a surgery or lose weight, we can actually see benefits, I would say, within weeks to months. Yeah. And just a little pause before we go on to our next topic. This is Diamond Head in Honolulu, Hawaii. Recently opened. It was closed. The hike was closed for the pandemic. Alrighty, so moving on to the next topic. The next common condition I treat in my clinic is insomnia. And this is a lady talking maybe to her husband or her partner. No wonder you have insomnia. You're just lying there awake all night. And is that really what insomnia is? Well, let's dive right in to find out. So insomnia is threefold. Difficulty falling asleep, staying asleep, but also it needs to cause distress during the daytime. It can impair the quality of your life. Chronic insomnia is if it's been going on for at least 3 months, right? If it's less than that, it could be more of just an acute stress reaction, but a condition that's been going on for 3 months is considered chronic insomnia. And there are different reasons why. This is called the 3 Ps of insomnia. For some people, there's predisposing factors. So maybe there's genetic traits, biological traits. Maybe your parents didn't put you on a specific regimen for sleep-wake when you were a kid. Maybe there's social factors that also been playing a role. Oftentimes, you find out there's more precipitating factors. So medical illness, someone's had a huge heart attack, they end up in the hospital for a couple weeks at a time, and then, you just don't sleep well, and in the hospital, they're always checking you. They don't actually let you sleep well. Some people have certain psychiatric illnesses. They're manic or they're depressed, and that really plays a role in how much sleep that they can get. Stressful life events, with COVID, there's been a lot of issues with mental health on the rise, families dying, people grieving, not being able to be with them. That can lead to certain insomnia. And even though those stressful events may have been in, a year or two past, people can continue to have difficulty sleeping. A common one is with pregnancy. When a young mom has their baby in a postpartum period, sometimes, depression is actually associated with difficulty sleeping or not being able to sleep, having sleep deprivation. And sometimes those patterns when the baby's crying and sleeping, people have a hard time sort of recovering for that. So I've had patients who've had 10 years of insomnia and their kids are already, in elementary and they're sleeping through the night, but they still have a hard time sleeping. So sometimes those are precipitating factors. Perpetuating factors, these are important because if we can identify these, then we know how really to help improve the insomnia. Some people just spend too much time awake in bed, and it's really better only to use your bed for intercourse and for sleep because your brain doesn't want to associate being awake, sort of tossing and turning, being frustrated with being in bed. That's not a very helpful sleep association. Napping, sometimes napping affects our homeostatic drive, which affects how sleepy we are to allow us to sleep at night. And then there's certain conditioning around it. So, using our bed for other activities besides just sleeping. Yeah, so identifying some of these perpetuating factors will allow us to help treat the insomnia. Sleeping pills, I just want to briefly talk about this because this is really important. Sleeping pills aren't the cure. Just like when we take pain medications, they don't really treat the underlying cause. You break your arm, it hurts, so you're on pain medication, but it doesn't really do anything to set the bone, right? Maybe you need surgery, maybe you need a pin, maybe you need a cast. So sleeping pills are only moderately effective for treating sleep apnea, and they can have serious side effects. In elderly people who use sleeping pills, they have a higher rate for morbidity and mortality, meaning more health problems. They wake up in the middle of the night, a little bit drowsy, groggy, fall and break their hip. Sleeping pills have also been associated with, dementia and memory issues. They can stop working over time. People can develop a tolerance to them or tachyphylaxis after a while. You need higher and higher doses, and that actually isn't good, right? Because the more medication you take, it can have a higher side effect profile. People can become dependent on medication. I've had some patients who want to get off the medications, don't necessarily know how. We do this cognitive behavioral therapy classes for this. And then what they noticed is that even though they're off the medication, they're sleeping the same amount as they were with the medication. So is the medication really doing anything over a while? And just like I talked about pain, right? Sleeping pills don't cure insomnia because they don't treat the underlying cause. So the first step is always to try to identify the underlying cause, because we know the root cause, then we can help a patient in their journey to help them sleep again. And insomnia returns when the medications are discontinued. And can be really bit hard, because as you wean someone off the medication, as you slowly take them off, you can have rebound insomnia. Yeah, which can make it hard, and then they don't want to stop. They don't want to not take the medication. So going back to my field of integrative sleep medicine, I certainly look for natural approaches. But if you look at the recommendations by the American Academy of Sleep Medicine, which is a national body in America for sleep medicine physicians, and also the American College of Physicians, which are the doctors for adults, they recommend CBT for insomnia. So what CBT is cognitive behavioral therapy for insomnia. So cognitive behavioral therapy, right, is using your brain, using your cognition, teaching someone how to sleep better, right? Because if we can train someone to sleep better, then they can sleep better. So a good analogy is, your computer operating system, right? Your OS, right? So for whatever reason, there's precipitating, there's predisposing factors where someone has been essentially programmed, have a program for insomnia in their brain, their CPU. And so what CBT does is basically up levels that, right? Puts in new programming to teach someone how to sleep again. Yeah, and it's pretty powerful. It does work. It's not 100%. Some people are quite attached to their thoughts, and so if you're unable to change some of those thoughts, then it won't get better. But there are a lot of good treatment options for it. Mindfulness can really help. Moment-to-moment awareness. Sometimes that's what mindfulness is. Sometimes people have difficulty sleeping because they're constantly worrying. They have ruminating thoughts, and so if you're able to sort of zone those things out, clear their mind, and just focus on the present moment, that can help. Clinical hypnotherapy. Clinical hypnotherapy is tapping into the subconscious, getting the brain into a really sort of restful state. And in that state, you can add suggestions for clinical improvement, and it works well. I use that in my clinic with some of my patients. And herbal supplements, right? So herbal supplements probably have a lot least side effects as compared to hypnotic agents. What sleep is when the brainwaves start to slow down. So there are herbal supplements that do have some evidence to support it. However, one caveat is I certainly don't like patients to be dependent on a pill because sleep is natural. So if we can train you to sleep again, right, improve your operating system, reprogram your mind, to sleep, then certainly it's better. And you're not reliant on herbal supplements, right? Because, training your brain essentially can be free or pretty low cost, and there's multiple ways to do this. Some of the natural supplements are listed here. Essentially, a lot of them work on GABA, which is a protein in the brain, a neurotransmitter as well. Yeah, valerian root, lavender capsules, 5-HTP, magnesium, hops, chamomile, and L-theanine. This is a picture of a lavender field here. Lavender is really interesting in nursing homes. There are some stall studies where patients are on benzodiazepines, anti-anxiety medications for pills. And like I said, in elderly patients, you don't want them on these type of sleeping pills because they can wake up and fall and break their hip. So they've actually, as they were weaning someone off of it, meaning slowly tapering them off of the medication, they were using oral lavender capsules, and it actually helped patients reduce the side effect profile in the rebound insomnia. They found it actually works on a similar the GABA receptor in their brain. So it's really interesting how there's natural ways that we can help support our patients. 478 breathing. So part of integrative medicine is mind-body practices. So going back to what sleep is, right? Sleep is when the brainwaves start to slow down. You're supporting the parasympathetic response, which is the relaxation response. Sometimes, we're go, go, go all the time. Our sympathetic drive is really turned up. We have a lot of adrenaline, which is good to have that, except at night when we're trying to sleep, we want to sort of slow down our thoughts, slow down our brain. One of the quickest ways to go from the stress response to the relaxation response is to do this, right? So I'm sure you've seen someone who has a panic attack, or maybe you've noticed yourself having some anxiety. What do? Well, you start breathing fast. and shallow, right? So how do we turn that off? If you want to turn that off, I certainly suggest to turn that off. And it's to train your brain, train your breathing pattern, right? So one of them is called the 4-7-8 breathing, because if you're able to focus more on holding the breath, slowing down the exhale, you can switch the systems. Meaning you can go from the stress system to the relaxation system pretty quickly, and you don't need a medication to do this. So this one is called 4-7-8. It's taught by Dr. Andrew Weil, who founded the U of A program that I went for integrative medicine. And what you do is you inhale for 4, take a deep breath in, hold for 7, and then you slowly exhale for 8. And this is one breath. So you do that for four breaths. Yeah, and it really works well. I recommend for patients to do it twice a day, in the morning when they wake up, and then before they go to bed at night. But certainly you can do it multiple times throughout the day. As opposed to benzodiazepine medication, there's really no side effects for this. It's free. For some people, if they're not used to deep breathing, maybe they can feel lightheaded or dizzy. Restless leg syndrome is another condition that we treat. It's a creepy crawly. It's described as creepy crawly, electric currents, crazy legs, ants, or crawling pain. It can keep someone from falling asleep. The mnemonic is urge to move your legs. Rest makes it worse. Gets better with movement and activity, and gets worse in the evening time. Associated with these things here, pregnancies, kidney failure, peripheral neuropathy, and one thing to keep in mind, it is associated with low iron levels. So if you have low iron, then supplementation can make it work. There are medical treatments for it, Requip and Maripix. Interestingly enough, benzodiazepines and opioid medications also work, but we don't really want to put patients on this. Stretching can help, and magnesium can help as well. So magnesium is really good for people who have restless legs, but also to help someone fall asleep as well. Parasomnias, I'll talk briefly about this. What a parasomnia is abnormal movement when someone's asleep. So sleepwalking is probably the most common one, or sleep talking. For kids, sleep terror, so kids who wake up in the middle of the night, really unconscious of what's going on, and they're just screaming. It happens more in stage 3 sleep, which kids have, and as they go through puberty, have less and less of this. Nightmares is considered parasomnia. Sleep paralysis, people who wake up and their bodies are paralyzed, they can't move. This is actually a protective mechanism that occurs during REM sleep. So REM is a part of the night when you're dreaming. Some people don't have that paralysis. This can be normal, but can also be associated with sleep deprivation, untreated sleep apnea. And then REM behavior disorder. So REM behavior disorder is really interesting. It's associated with Parkinson's condition, and this is when people who don't have that paralysis, they start to act out their dreams, right? So they're fighting, kicking, punching. They can actually be physically assaulting their bed partner, and there have been some legal cases about that, but actually has been found out to be an actually underlying neurologic condition. Some of the parasomnias can be mistaken for seizures, so if this is something that someone has, I do always recommend to see a sleep physician or neurologist about it. Narcolepsy. So narcolepsy, I think this is the final medical condition I'll talk about. Not as common as obstructive sleep apnea, but probably more common than we think. Maybe more common after the COVID pandemic is over, and I'll explain why. So we have different stages of sleep, stage 1, stage 2, stage 3, and then REM sleep. What happens in narcolepsy, it's not quite what Hollywood shows. Hollywood shows that someone's like talking, and then they just, sort of zonk out sleeping. Really what they're trying to describe is cataplexy. So cataplexy is with an emotional trigger. You lose all muscle tone. So say if I had a cataplexic event, I'm holding this, someone makes me laugh, and I drop my cup. I have some patients who can't be around some of their really funny friends, because if they are, they'll collapse to the ground. So usually if they are, then they're seated. What narcolepsy really is patients are tired all the time because they're in and out of being awake. They're in REM sleep, they're awake, they're in non-REM. They can be waking up and seeing their dreams, going to bed and actually seeing their dreams, feeling like they're hallucinating, and also having that sleep paralysis. Their brain's waking up before their body's waking up, so they just can't move. And these patients are tired all the time. Happens in young kids. It can happen, teenagers, 20s, 30s, and 40s is usually when we diagnose it. Why did I mention COVID? Well, actually, after the SARS pandemic, there was an uptick of narcolepsy cases in China. Why is that? Because there's an immune response. There's an immune response that can actually affect a hormone in your brain called orexin, and orexin helps keep us awake. So we'll see in the next subsequent years if we have more narcoleptic cases. How do we treat narcolepsy? Well, support the sleep. There's a medication called Xyrem that helps put people in a deep sleep. It's known as gamma hydroxybutyrate. And then there's other medications that we can help support the wakefulness. Stimulant medications, Adderall, Ritalin, and also newer medications as well. Pretty difficult condition to treat. I have some patients on multiple stimulant medications, and they are still quite tired. So in summary, what's my advice for pre-medical students? You know, if you can tell I'm, that integrative state, I really like to focus on the mind, psychology. I was a neuroscience major, so self-development is so key. Thinking about what your values are, are they in line with becoming a doctor? What kind of doctor? Working on your beliefs, because certainly if you have a goal, you're able to obtain it. And your brain actually is so brilliant, it'll help you come up with the how. Sometimes the how is a big question mark, but just know that I think you're stronger, you're stronger and smarter and more resilient than you think you are, and it's going to be okay. I think, I gave a talk recently, it's like, what would I tell myself? Probably stop worrying so much. I was very nervous. I didn't sleep. I stayed up all night. I didn't know all this research about neurobiology, neuroscience of sleep, and I was doing everything I would say wrong. Now that I know, my message is to really get an adequate amount of sleep and love yourself, right? Work on your self-development, work on your beliefs. We need more doctors. Certainly, there's a huge doctor shortage in the state I am in. I do telehealth, and there's so many patients that say, can you help me with my refills? I moved state, I can't find a new doctor, and I've been searching for months. So the world needs you. The world needs more pre-medical students to fill our slots as we get older. And how can you best prepare for the rigors of medical school down the line? Well, it's going back to, I think, self-development, knowing who you are, what's your motivation, what's the direction that you want to take. But always remember self-care, right? You can't pour from an empty cup. Make sure that you're exercising. Make sure that you're socializing, with your friends. And, it gets certainly difficult once you're in medical school and your friends that you have outside of medical school, you may not be able to talk to as often, but make sure that you're eating well, you have good nutrition, that you are sleeping, that you are exercising, right? Your brain will work a lot better, and you certainly need your brain to be able to get through the rigors of medical school. I think that's all. Any questions? And this is how you can contact me. I recently created a TikTok account called Dr. Val Sleep Val with some sleep tips. My personal professional Instagram is here, and I actually have two business websites. Sleephoria.health is an online education company that I'm creating for women's health, and then my private practice is called Sleep Life Med. Thank you so much. Happy to answer any questions. Welcome, Farah. Thanks for spending your Sunday afternoon with me. Thanks so much, Eunice. Well, I didn't include sort of normal sleep data here, but for those 18 and above, it is recommended to get at least 7 to 9 hours of sleep at night. Yeah, and there is a thing called social jet lag. So if you're sleeping in longer on the weekends, it's actually better to have at least 7 to 9 on a regular basis, right? We are creatures of habit. So if we're feeling that we need to catch up on the weekend, you may want to examine some of your activities. Because you can't actually make up on sleep. Yeah, so sometimes people think, well, I'm going to sleep less one night, I'll just sleep longer here. It doesn't necessarily work that way. You can't bank sleep. Yeah, you can create a sleep debt, but you can't bank for more sleep in the future.
Perfect. If you guys don't have
Yeah.
any more questions, I think I would like to end this session, as I know like Dr. Valerie, uh, I would like to respect her time as well. But as she said, just feel free to contact her in any kind of questions that you guys have. And I would like to once again thank you, Dr. Valerie, for coming and just giving advice to us and just informing us in this great field of sleep medicine. I think a lot of pre-medical students like kind of like don't think about sleep as that important factor. So just um, illustrating the importance of sleep and just kind of showing us like how amazing it can be was really informative. um, Again, like don't forget to fill up the assessment form for everyone who wants to get your hours counted for this session. It should be in the chat section, and pass with a minimum of 70% to get your hours. Stay tuned for our upcoming e-sharing session happening tomorrow on March 29th at 3:30 p.m. With Dr. Julie Lamb, who will be talking more on the field of gynecology and will be teaching us. So thank you everyone for coming, and thank you again, Dr. Valerie, for joining us.
My pleasure. Have a wonderful evening, everybody. Bye bye.
Bye.